Okay, I will present our next speaker, Dr. Eman Nada, Assistant Lecturer of Pathology at Faculty of Medicine, Swiss Canadian University, and her presentation is entitled "When It Becomes a Place for Everyone Else," or when it becomes a home for everyone else.
Good afternoon, everyone. My name is Eman Nada, and I'm an Assistant Lecturer of Pathology in Swiss Canadian University, and I'm presenting a case with the title "When It Becomes the Home for Everyone Else." This case is under the supervision of Dr. Mohammed Kamer al-Kharbitawi, Lecturer of Pathology in Swiss Canadian University, Faculty of Medicine. Regarding the clinical data, she was a 66-year-old diabetic female presented to the daycare oncology clinic with suspicious left breast mass, diffuse podorange thickening of the overlying skin, and enlarged ipsilateral axillary lymph nodes, along with ipsilateral supraclavicular and cervical lymphadenopathy. Superficial target ultrasound and CT chest.
في حاجة بتدعم الجهاز تقفليها، أي برامج تانية أو حاجة بتعمل بتبطئ الجهاز أو كده تقفليها وتفتحي بس الباوربوينت وخلي.
Should I continue?
Doctor, continue, yes.
Okay. Superficial target ultrasound and CT chest showed an ill-defined heterogeneous hypoechoic lesion seen at the 12 to 3 o'clock area, measuring about 5.5 by 2.7 centimeters, thickened edematous overlying skin, multiple enlarged left axillary lymph nodes with enlarged left internal mammary, left supraclavicular, and left cervical lymph nodes, groups 1 to 6. So an ultrasound-guided core biopsy was obtained and sent for histopathological examination, and the gross picture showed 3 soft tissue cores ranging in size from 1.5 to 1.9 centimeters and small tissue fragments. Microscopic examination revealed the infiltrating tumor tissue formed of irregular groups of moderately pleomorphic malignant epithelial cells with score 2, with poor attempts at tubular formation, score 3, and moderate mitosis, score 2. There was moderate dysplasia, tumor-infiltrating lymphocytes were about less than 5%, and no ductal carcinoma and cytocomponent was detected. And here we can see the infiltrating groups of malignant cells within moderately desmoplastic stroma. And a higher magnification on the tumor cells, they were moderately pleomorphic and of epithelial type. Our immunohistochemistry panel involved estrogen and HER2, and they were both negative. It was positive for PR with moderate nuclear staining, and the Ki-67 proliferation index was 60%. This is a picture of a negative ER. This is a negative HER2. And this is the positive progesterone, which was a bit confusing at the beginning. And this is the Ki-67 with a 60% proliferation index. So based on the microscopic picture and the immunohistochemistry results, the initial diagnosis was infiltrating duct carcinoma grade 2 of the triple negative type. But is that all? The patient had extensive nodal involvement, not just to the axillary groups, but also to the internal mammary, the supraclavicular, and even the cervical lymph nodes. This picture didn't really fit the expected classic presentation of advanced breast cancer, and that didn't really sit with us. Could there be a more serious hidden primary tumor presenting itself through those secondaries? So we contacted the referring surgeon requesting a more detailed present and past history of this patient before signing out the report. And the surgeon answered that the patient actually had a history of a large neck mass. So we decided to take a second look on the breast mass slides, and we found that most of the tumor cells were of a small size with scant cytoplasm, and the nuclei were small, hyperchromatic with inconspicuous nuclei, There were foci showing nuclear molding, as we will present in the next slide, and there is focal crushing artifact, as seen here. And this picture shows better nuclear molding. And accordingly, we decided to expand our immunohistochemistry panel to add chromogranin, and it came out positive, as shown here in the slide. And on account of that, the provisional diagnosis was breast neuroendocrine carcinoma. But the next question is it really of breast origin? So we added TRPS1 and GATA3, and they both came out negative, as seen here. This is the TRPS1, and this is the GATA3 negative. So the answer was no, it wasn't, apparently wasn't of breast origin. So we thought, could it be related to the neck mass? We reconsulted with the surgeon and rechecked the patient's clinical and radiological data. And the CT scan on the neck showed a large ill-defined heterogeneous neck mass. Actually, it was occupying most of the left side of the neck, and it was inseparable from the thyroid. And diagnosed previously by biopsy and immunohistochemistry as a neuroendocrine tumor. And the patient's serology showed a high serum calcitonin. And this immunohistochemistry staining shows, quickly we ordered a calcitonin staining, and it showed a moderate cytoplasmic positivity, as we can see here. And we also ordered the TTF1 and was also moderately positive. So the final diagnosis was metastatic medullary thyroid carcinoma to the breast. And going a little through the literature, we found that metastasis to the breast from a primary malignancy arising in another site is generally a rare condition, representing less than 1% of all breast cancers, and is more common in women. It can lead to misdiagnosis due to the overlapping morphologic and immunophenotypic features with a primary breast carcinoma. Hence, an adequate clinical history is necessary for accurate diagnosis. And the most common cancers metastasizing to the breast is the malignant melanoma, particularly of the cutaneous origin, representing 38.5% of all the breast metastases, followed by adenocarcinoma and small cell cancers, particularly of pulmonary origins, representing 24.9% and 8.8% respectively. Then neuroendocrine tumors representing 7.1%. Although they came fourth, neuroendocrine tumor metastases in the breast represented a prognostic advantage, with a median overall survival of 18.5 months compared to 9 months of those of the non-neuroendocrine histology. About the medullary thyroid carcinoma, it's a rare neuroendocrine tumor that accounts for 1 to 4% of all thyroid cancers, and it originates from the parafollicular C cells of the thyroid. Its pattern of spread is predominantly lymphovascular. Metastasis occurs early to the local lymph nodes, such as the paratracheal and the lateral cervical lymph nodes via lymphatics, and then spread outside the neck occurs later in the course of the disease via venous invasion, commonly to the liver, lungs, bone, and less frequently to the skin and brain. It's positive for calcitonin, chromogranin, along with the other neuroendocrine markers, TTF1, and the progesterone, and that explained the positivity of progesterone in our case. Metastatic thyroid carcinoma of the breast is an extremely rare condition, with 20 reported cases to our knowledge. 19 of the 20 cases were reported in females. The interval between thyroidectomy, if done, and detection of the breast metastasis was between 0 to 28 years, with a median of 6 years, and the mean age at diagnosis of 42.5 years. Only 2 20 patients have metastasis to the breast at an initial site of presentation. And now I'm gonna show you some other interesting cases of cancers metastasizing to the breast. Besides my case, this is a medullary thyroid carcinoma presenting metastasis to the breast at an initial presentation. This is another medullary thyroid carcinoma presenting or metastasizing to the breast. And medullary thyroid carcinoma also, but in a male patient. This is a papillary thyroid carcinoma with breast secondaries. And even the thyroid follicular carcinoma, but this case is a 90-year-old patient having the metastatic thyroid follicular cancer in the breast after 12 years after thyroidectomy and radiotherapy. This case is of metastatic melanoma of unknown origin to the breast. And ovarian cancer also metastasizes to the breast. And this is a case of ovarian serous adenocarcinoma. And this serous carcinoma also metastasizes to the breast, and it caused inflammatory breast carcinoma. And its markers showed it was ovarian origin. At first, they weren't sure if it's ovarian or peritoneal, but it came out ovarian. And kidneys too. Renal cell carcinoma also causes breast secondaries. And finally, colorectal cancer. And personally, I was left with a question that isn't it enough for the breast to bear its own primary cancer as the most common cancer in women? And the answer was apparently no. Apparently, it also can be the home for everyone else. Thank you for your attendance.
Thank you so much, Dr. Eman. A very interesting presentation, very interesting case. Thank you so much for your effort.